professors and colleagues. I'm very pleased to be with you today. My name is Ashraf Al-Maraghi. I am an assistant professor of chest diseases at Shams University, Cairo, Egypt. I will talk today about the utility of integrating basic echocardiography in routine respiratory intensive care practice on behalf of my colleagues, co-authors of this study. As a start, in a critically ill patient, the diagnostic methods must be rapid, reliable, and reproducible to confirm a successful therapeutic strategy, as the patient is under an intense threat for his life. Cardiac abnormalities are common in critically ill patients and may be unsuspected on clinical examination despite their hemodynamic significance. Basic echocardiography can be used for the assessment of global and regional left ventricular systolic function and right ventricular impairment. The aim of this study was to evaluate the impact of integrating basic echocardiography in routine assessment of patients admitted to the respiratory intensive care unit and to assess its effect on the outcome of these patients. This cross-sectional study was done prospectively on 300 patients admitted to the respiratory intensive care unit at Abbasiyya Chest Hospital, Cairo, Egypt. No specific contraindications existed in the procedure. Informed consent was obtained from all patients or their relatives, and the study was approved by the Institutional Ethical Committee. Baseline bedside scanning of patients in the respiratory intensive care unit on admission for basic echocardiography was performed by portable echo machine using the phased array 2.5 MHz transducer for better resolution of the heart. Basic echocardiography was performed by a certified pulmonologist and reviewed by an experienced cardiologist in all cases as gold standard. Patients were scanned either in supine or left lateral as tolerated position. Transthoracic echo views were obtained and recorded as possible in the parasternal long axis, parasternal short axis, apical 4-chamber, apical 2-chamber, and subcostal views. The average time needed to complete basic echocardiography scanning was 10 to 15 minutes. Basic echocardiography was done to assess the following: the pericardium for moderate or large pericardial effusion and cardiac tamponade, left ventricular size and function, where visual estimation of global and regional ventricular contractility were assessed, right ventricular size and function to detect the presence of pulmonary hypertension, right ventricular hypertrophy, right ventricular dilatation, right atrial dilatation, and right ventricular failure. The right ventricular over left ventricular ratio greater than 0.6 was considered as indication of significant right ventricular overload. Valvular anatomy and function, where crude valvular mobility, valvular incompetence, valvular stenosis, defined as thickened leaflets with restricted mobility, and valve prothesis were also evaluated. Also, basic echocardiography was used to assess the inferior vena cava diameter and collapsibility through the following: sonographic measurement of inferior vena cava and conventional venography, that is to say, heart rate, blood pressure, central venous pressure, and hemodynamic and intravascular volume status variables were recorded. Inferior vena cava collapsibility was computed based on the minimum and maximum inferior vena cava diameters and determined by M-mode ultrasonography on the vein wall. The collapsibility index, which is also known as the caval index, is defined as the maximal diameter of inferior vena cava minus minimal diameter divided by the maximal diameter. Finally, we scanned the lower limbs for deep venous thrombosis if necessary by limited compression ultrasonography using linear transducer ranging from 5 to 13.3 MHz. Limited compression evaluation was done for specific areas of the leg, including common femoral vein, deep femoral vein, saphenous vein, superficial femoral vein, and popliteal vein behind the knee. The pathognomonic sonographic finding of DVT or deep venous thrombosis is the incomplete compression of the anterior and posterior walls of the vein with applied probe pressure. As regards the results, a total of 385 patients were admitted to the respiratory intensive care unit all through the duration of our study. 85 patients were excluded because morbid obesity in 9 patients with no echocardiography window for examination. 34 patients died before scanning during the first 24 hours of admission, and 42 patients were missed because of unavailability of a sonographer. So a total of 300 patients admitted to the respiratory intensive care unit were enrolled in this study and included 221 males and 79 females with mean age of 52 plus or minus 17.3 years, ranging from 13 to 96 years. The indications for admission at the intensive care unit included 46.3% of patients had respiratory failure type 1, 9% of patients had respiratory failure type 1 and shock, 43.3% of patients had respiratory failure type 2, and 1.3% of patients had respiratory failure type 2 and shock. This is a list representing the underlying illness among the studied group, which included COPD exacerbation, which was the most frequent underlying illness, also pneumonia, pulmonary tuberculosis, interstitial lung disease, pleural effusion, lung mass, pneumothorax, lung abscess, bronchiectasis, acute severe asthma, pulmonary edema, and pulmonary embolism. When we assess the impact of basic echocardiography on diagnosis, first of all, basic echocardiography added unsuspected serious conditions to the diagnosis in 33 patients, representing 11% of the studied population, in the form of 5 patients with massive pericardial effusion, 22 patients who required inotropes because of dilated cardiomyopathy in 11 patients and ischemic cardiomyopathy in 11 patients, 5 patients with deep venous thrombosis, and 1 patient with aortic aneurysm. Basic echo also confirmed 7, representing 2.3% of the population with massive pulmonary embolism, and 13 patients representing 4.3% of the total population with deep venous thrombosis. On the other hand, basic echocardiography changed the diagnosis by exclusion of infective endocarditis in 18 patients, lower limb deep venous thrombosis in 32 patients, ischemic cardiomyopathy in 3 patients, massive pulmonary embolism in 3 patients, and dilated cardiomyopathy in 2 patients. The other phase for assessing the impact of basic echocardiography is to assess its effect on the plan of management. Basic echocardiography supported the use of anti-ischemic measures in 8 patients with ischemic cardiomyopathy. Fluid resuscitation was supported in 17 patients, fluid restriction was supported in 6 patients, and therapeutic anticoagulation prescription was supported in 16 patients. Screening with basic echocardiography added to plan of management medical treatment in the form of therapeutic anticoagulation to 8 patients, anti-ischemic measures to 28 patients, post-op inotropes to 22 patients, diuretics to 27 patients, thrombolysis with streptokinase in 7 patients with massive pulmonary embolism. On the same track, basic echocardiography added to the plan of management certain procedures in the form of surgical intervention was recommended for valvular repair or valvular replacement in 20 patients with persistent infective endocarditis and in 4 patients with tight mitral stenosis. Pericardiocentesis was performed in 2 patients with cardiac tamponade. Follow-up of diagnosed pericardial effusion was performed in 4 patients because of moderate amount and in 3 patients with massive pericardial effusion for fear of cardiac tamponade, and follow-up echocardiography was done after pericardiocentesis in 2 patients. On the contrary, basic echocardiography changed the plan of management in the form of intravenous fluids were discontinued in 19 patients. Anticoagulants were discontinued in 3 patients. Antiarrhythmic drug was discontinued in 1 case because of detection of right atrial thrombus. Positive inotropes were discontinued in 1 patient because of severe aortic stenosis. Antibiotics for infective endocarditis were prescribed in 20 patients. In order to verify the findings of basic echocardiography, we compared between the basic and standard echocardiographic findings. Comparison between basic echocardiographic findings as done by the investigator, who was the pulmonologist, and the standard echocardiographic findings as done by the expert, who was the cardiologist, showed that there was no significant difference in proportion in each category, basic and standard echo, and the expected proportion, except in probable incompetence of tricuspid valve and probable normal tricuspid valve. The p-value was less than 0.0001. This indicates that the basic echocardiography was able to read the whole findings data as compared to standard echo, except with probable incompetence of tricuspid valve and probable normal tricuspid valve. The standard echo had the upper hand. The basic echo at probable incompetence of tricuspid valve had the minimum sensitivity, 30%, minimum negative predictive value, 63%, and minimum accuracy, 68%, even with 100% positive predictive value and specificity. This table shows the range of sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of basic echocardiography. As a conclusion, in a critically ill patient, basic echocardiography can readily provide adequate information to get a successful diagnosis and can diagnose life-threatening conditions missed at the primary assessment in patients admitted with acute respiratory symptoms. Basic echocardiography can also be used as a monitoring tool to guide management in critically ill patients. Inferior vena cava sonography provides a valuable tool and more practical approach in assessing intravascular volume, status, and guidance of fluid and vasopressor therapy for critically ill patients. Standard echocardiography is complementary to basic echocardiography in valvular lesions, especially tricuspid valve lesions. So I came to the end of my presentation. It was honorable for me to be with you today. Wishing you all the best and see you soon, inshallah. Thank you so much.